This is a case without a final diagnosis, despite a thorough evaluation. She was a 40-year-old paratri, all alive, a divorcee. Her last childbirth was 13 years prior to presentation. She presented in February 2024 with 2 months history of amenorrhea, shortness of breath, abdominal swelling, and pain. There was history of weight loss. She was actually admitted in the accident and emergency where she presented with acute symptoms. Ultrasound scan done then revealed massive ascites with query uterine mass with bilateral pleural effusion. CT scan also showed massive ascites, query cause. Renal function tests, liver function tests, viral markers, MUM2 tests were all negative. Chest X-ray revealed bilateral pleural effusion. MUM2 tests were also negative. A repeat scan at the gynecological unit was suggestive of mucinous cis adenofibroma. So this was the video done in the gynecology unit. So you can see this huge cysts with low level echoes. Here, not this lesion is heterogeneous and moves with probe pressure. So this tells me that this is not a solid lesion. It's likely to be some amorphous material. But below this lesion, I was not sure of what this is. And look at this extensive shadowing below this. So I thought this is likely to be a papillary projection of cis adenofibroma casting this shadow. Here you can see the bowel here. This shadow is coming from the bowel. So on color, you can see that the color uptake is somewhere here, and not part of this area takes up color. You see that? Part of this area has taken up color. Again, this is bowel with shadowing, not the low level echoes. So, but if you look at this particular lesion, which I assume to be some amorphous material, you can see it hasn't taken up color, suggesting that this is not a solid lesion. But somewhere here you can see a flicker of color here and a flicker of color somewhere here. So my working diagnosis was cis adenofibroma. But what happened at surgery? You can see the patient. Before making my incision. And lo and behold, when I made my incision, there was no cyst. It was this bloody collection in the peritoneal cavity. There was no cyst whatsoever. And those amorphous materials I saw on ultrasound scan, I didn't see at laparatomy. For me, this is the first time I encountered a frozen abdomen. I've seen a good number of frozen pelvises, but not frozen abdomen. So here you can see the liver here, the spleen, nothing, plastered from up down. So you couldn't visualize any of the abdominal structures. What we observed was that there are multiple nodules on the anterior abdominal wall. You can see this. These are multiple nodules. So we concluded that this is likely to be tuberculosis. But interestingly, these areas, when biopsies were taken, the areas bled torrentially. And when I discussed with the histopathologist, he said, but tuberculosis does not present that way. I agree with him. But here we have these nodules, which we suspected to be tuberculosis. And of course, we took multiple biopsies, as you can see. This is one of the biopsies is a good chunk. So, what did the biopsy reveal? Sections show tissue composed of constellation of blood vessels, nerve bundles, adipose tissue, and few sprinkles of lymphoid cells with edematous stroma. There is no evidence of malignancy or granulomatous inflammation. So we are left at a loss, really. If the histology did not support our working diagnosis, and this is not a case of malignancy. So what else could this be? So we commenced the patient on empirical anti-TB. More so that the ESI was 115, although the Maslow's day was negative. Interestingly, the pretreatment weight was 45, and the weight improved to 54 1 month after commencement of anti-TB, and she was fully back to her normal chores after completion of 6 months course of antituberculous treatment. But these images were obtained 4 weeks after surgery and before commencement of antituberculous drugs. So you can see that there was still some remnant of this intraperitoneal low-level fluid collection. You can see that. And look at the bowel here, and look at this layer here that conceals the abdominal organs. You see that? This layer, and you can see the bowel below this layer. So here you can see this is a low-level echo. This layer that form what looks like a frozen abdomen and the bowel. So these images were obtained 4 weeks after surgery, but before commencement of antituberculous treatment. So I decided to call the patient back 9 months after completion of therapy. So what did I find? Brother underfield. So look at this. This right tubo-ovarian mass. Look at the tube here. With tablet content, thick. Look at the large over here. And in between, look at the omentum. Between the thickened fallopian tube and the ovary. But this patient was asymptomatic. I just called her back to evaluate. And again, look at this. Fluid reaccumulation. Similar contents. Low level echoes. So, what could this one be? We suspected it was cystic adenofibroma. Open her up with just collection in the peritoneal cavity. We took biopsies. No diagnosis. We sent the patient on antituberculous treatment. Patient improved, but 9 months after completion of treatment, this is what we observed on ultrasound scan. But patient was asymptomatic. So look at the still image, the tube, part of the ovary, part the omentum between the tube and the ovary, forming like a sandwich. Look at the collection here. So now comparing the images before and after empirical treatment for tuberculosis. So the low level echoes, the amorphous material, and the huge nature of what I thought was fibroma. This was before conventional anti-tuberculosis treatment, 4 weeks after surgery. In both of this, patient was symptomatic. But now, 9 months after completion of therapy, patient was asymptomatic. I just called her back to document and see the changes. And I was surprised to encounter this reaccumulation of similar fluid and the presence of the tubo-ovarian lesion. Let's remember that the fallopian tubes are the commonest sites of female genital tract tuberculosis. The ovary is also affected in about 30% of cases. So, but could this still be a case of female genital tuberculosis or something else? Of course, endometriosis can mimic this, but we have ruled that out, especially with the pleural effusions. I thought it was catamenial pneumothoracis. That was not the case. So what is now the final diagnosis in these patients? Thank you very much for listening.